Okay. This webinar. Okay, where is? Oh, here. I'm gonna stop sharing really quick. Let's see. I'm gonna go ahead and share really quick. Looks like we've got some people joining.
Tanya, will you be monitoring the chat? I meant to ask you that earlier.
I can monitor the chat, and then if there's anything specific that needs to be asked, I can either shoot you a chat or I can ask it, monitor that.
Okay, I actually love it when we integrate like questions during the conversation instead of waiting until the end.
That's fine.
So if you,
That's fine.
yeah,
too.
if you want to interrupt, if you want to interrupt or what, me or whatever, find the right, jump in, because I think that's a good way just to keep it more conversational.
Okay. Okay.
Yeah, I totally agree. Sounds great.
All righty. So we still have some people trickling in, and for those of you have joined, I will be starting in about 1 minute. I just want to give everybody a chance to get on so we can start. All righty. I hope everybody that has joined can hear me. I'm assuming they can. All righty. I'm going to go ahead and get started now. And for those of you who have joined, welcome to Care Innovation, what's working and what's not. We are going to go through some HIMSS Arizona chapter. We want to welcome our sponsors, give them some recognition. Without their support, we would not be able to do these types of events. So thank you for all of them who support our chapter. The HIMSS vision to realize the full health potential of every human everywhere, and our mission is to reform the global health ecosystem through the power of information and technology. We are honored to be able to put on these webinars to share with our community as well. So thank you for joining. Just a couple things to run by. We are hosting, obviously today we have the Care Innovation, What's Working and What's Not webinar. Don't miss September 22nd, next Thursday, for our casual meetup from 5 to 8. The event is being held at, you'll have to look on our website. It is actually in one of our board members' offices, so please be sure to look that up. That's my fault, I should have had that. And then our annual summit, don't miss that. You are able to buy tickets now. The registration is now open, and that is Friday, October 14th. So make sure you check out our website to check all of those events. All righty. So today we are with Tina Burbine. She is actually a past board member of the HIMSS Arizona chapter, but also VP of Care Innovation with Healthlink Advisors. Tina has over 25 years of value-based care, population health, and healthcare IT experience. So she will be moderating our panel guests today. She has focused on shaping the strategic approach for health systems moving to value-based care enabling teams to focus on keeping their patients healthy, addressing rising risk, and improving the health of those chronic conditions. So welcome, Tina. She will be speaking with Dr. Erika Bauman. He is award-winning educational designer, author, and proven innovation leader. He promotes interprofessional collaboration to support and drive simulation and game-based technology solutions for education. Demonstrated expertise in the areas of curriculum design, implementation, evaluation, and research for emerging and innovation technology, including game and mobile-based teaching and learning. So welcome, Dr. Bauman. We also have Dr. Erika Pabo. She is the Chief Transformation Officer for CenterWell and Conviva for Humana. Dr. Pabo is an executive leader and social entrepreneur with deep experience in value-based insurance and care delivery, who is committed to transforming the healthcare system into one better able to meet the needs of individual patients and populations at a cost that is sustainable to society over time. So thank you all for joining us today. For our participants who have joined this webinar, please feel free to ask questions in the Q&A box or the chat, and I will deliver them to the panel. And if you are taking this webinar for CE credits, please make sure that you log into HIMSS National and claim those credits accordingly. If you have any questions, you can reach out to the HIMSS Arizona chapter. So now I'm going to turn it over to Tina to start the session. Thank you.
Thanks so much, Tanya. You know, as we were preparing for this discussion today, I really appreciate Erika and Eric's time, because I think their unique perspectives from their backgrounds in healthcare, being both on the provider side and having some input into the insurance payer side, really brings both a unique perspective and some really exciting things that we can talk about when it comes to care innovation. So thank you both for being here, and anything else that you'd each like to add about your backgrounds or current roles?
Tina, really appreciate that HIMSS Arizona team hosting this and you kind of pulling us together and moderating the conversation. Because I've had the fun of sitting at that intersection of payer and provider most intensely over the last 4 years since joining Humana, but really it's where I've been sitting for most of the last 15 years as I've worked on particularly primary care transformation. But I think the two things probably most relevant to today's discussion is, until a few months ago, I was sitting on the payer side. So trying to reimagine care for seniors, but from a value-based insurance experience. So what would it mean to reimagine providing care through a Medicare Advantage program for seniors? And then I moved to the other side of that kind of divide a few months ago in joining Humana's payer agnostic care delivery entity that we call CenterWell and Conviva. We operated under 2 brands. And so I've been thinking about care innovation from a slightly different perspective, although all driving towards the same goal of the care that people deserve and being able to deliver on the vision of value-based care.
Yeah.
Sure, I'll say a few things about where I've been and where I am now, if you guys find that to be helpful. So I spent the last 15 years working in hybrid roles in academia and big business, with various appointments at different universities throughout the world, and also working for a Fortune 500 company involved in medical and nursing education. And so I've spent a lot of time initially thinking, how can we leverage technology and all the nice things that people said about me in my introduction? So how can we really leverage technology as it's booming forward for health sciences education? And I was getting a little bored of myself in that role, and decided I'm going to go back and spend a little bit more time in clinical practice. And so now I work part-time as a psychiatric nurse practitioner. Then all of a sudden we had a pandemic. And then all the things that I was bored of talking about and all the things that I felt like I was never going to make any progress with, like people were either going to be into technology or not. All of a sudden, there was no way to develop, there was no way to provide patient care, and there was no way to continue to progress the pipeline of clinicians and training. And all of a sudden, I got really popular again by doing nothing. So all of a sudden, over the last 2 years, my citations have gone from like 200 on some articles to 600. And I get a laugh out of it because some of these things I feel are pretty dated, and unfortunately, it took a world pandemic for people to say, oh, well, how are we going to provide any care whatsoever? And also, just importantly, is people I don't think realize that we now have brand new mentored nurses, physicians, RTs, PTs that did 50% of their training during a global pandemic, and that looks a lot different than the way you and I probably trained, Erika.
Yeah, I added it up. I got 60 minutes of training on telephone visits as a resident, and officially 0 minutes of training around any other sort of telehealth, asynchronous care. But there was one lunch discussion on what does it mean to provide care over the telephone. So yes, I think suffice it to say, I totally agree. I think their training was pretty different than that.
I think what both of you just mentioned is really, if there's a silver lining to the pandemic, it's the kind of change that it's forced us, to think differently about how we're delivering care now. I mean, there's definitely been a big push, not only to leverage things like telehealth and different virtual technologies to provide care, but also to do it in new and different settings, like driving it into the home for patients. And so as you were both describing the types of work that you've been focused on recently, I would love for both of you to share what are some of the care innovation projects that you've been a part of as a result of the pandemic. Dr. Pabo, would you like to start?
Yeah, sure. And I agree. It is probably the only silver lining that comes from something like COVID is it really changed the game and sort of jolted us at least into the current century. Because I think if you look at other industries, healthcare has been behind for so long in terms of really meeting our customer where they are and providing diverse channels or ways of accessing care. I think you look at really any other industry, and they were doing that long before COVID. But I agree, I was practicing I still practice as a primary care doc, very part-time, and I was practicing in a system before COVID. It was aspirational to think that we would do 1% of our visits over video. Like that was going to be a push. And then COVID happened, and overnight, within a 2-week period, we shifted from less than 1% to 95% of care being done virtually for those first couple of weeks, and then sort of shifted back to somewhere around 75% of care being done virtually for most of that first year. So during COVID, as COVID hit, I had the interesting position. I was actually in the process of trying to launch a new product. And we were actually just about to hire our frontline team, and we were going to host all these in-person sessions in South Carolina. We were launching to hire folks, and COVID hit, and we went home, and we had to figure out how to do all that virtually. And in a way, it was super interesting timing because we were trying to launch this sort of next generation experience for seniors, really new insurance experience, new care delivery experience. And we were forced to do all of that asynchronously and virtually. And I think having to do that actually as a team for the 9 months up to our product launch was a fascinating sort of push that put us in a much better position to actually provide those sort of omni-channel experiences and think about how to build relationships with our patients, because we had to do it ourselves as a team. Like we were forced to walk the walk. The office you see behind me is where our team sat, but we didn't have the opportunity because of COVID to work together as we were launching. Anyway, so I think it was a really interesting sort of foundational experience for what we called Author by Humana and Author Care, which were 2 products we launched early in COVID. And I think those were really trying to say, if you started from scratch in a value-based insurance experience and you just spent time with customers, listening to what they wanted and needed, and started over, what would you build? And a lot of what we built was focused on what they told us, and they told us they wanted a person. They wanted a person to help them navigate their healthcare experience, but they wanted that person to know them. They wanted that person to be available and accessible to them when they wanted and needed it, really for whatever they wanted and needed. And so it's an interesting blend of tech-enabled relationships, because what they wanted was the relationship, but none of what I just said could be accomplished without rethinking our technology stack in a different way. What does it mean to make sure whoever answers the phone knows someone? How do you reach them via whatever modality that customer wants, and provide them whatever clinical, administrative support that they need sort of in the moment? So it's an interesting blend that at the end of the day, what we heard is our customers wanted a person, but it required a total reset of our technology stack to do that efficiently and effectively for that patient and customer.
Yeah, I think two things I'll just briefly touch on. One, in terms of medical education. So anybody who has gone to medical school or nursing school in the last 10 to 20 years knows about the term simulation, or if you are a risk manager, you know about using these mannequins that are simulators to teach professional development and pre-licensure education, the same way we teach pilots to fly a plane. And for years, I'd sort of been saying that really this should be this continuum of learning. You have to read. I don't care if you read a PDF on your computer or your tablet or your phone, or you actually read the textbook, but then there needs to be something in between that mannequin-based, very expensive bricks and mortar training opportunity, than supervised clinical training, under the wing of your mentor. And people just didn't get it. Then we had the pandemic, and not only did all the hospitals sort of close, all the training facilities closed. And so over the pandemic, one of the projects I recently worked on was with the University of Maryland Medical Center with their neuro ICU attendings. And so there's this concept called, that's very expensive for hospital administrators. When things go wrong and there's sentinel events, a sentinel event costs millions of dollars, even just, never mind the liabilities, but the retraining and the investigation. So I had this problem called failure to rescue, where the nursing staff wasn't recognizing hypoxia or low oxygen saturations, or the resident was showing up and really didn't have the chops yet to be able to manage the situation. And they couldn't use their mannequin-based simulation laboratory because it was closed. So we developed an iPad application game that then that they could train all their staff there, but it would mirror the training that they would get in the simulation lab. So as the simulation lab would start to open, which would mirror best practices for patient care. And so we developed that application. You can go find it. It's called Distress exclamation point. And we're now starting the research protocols on, like, is this actually going to make a difference in terms of time to rescue for hypoxia in the neuro ICU. So that was like the educational component that I worked on. And what's interesting is, education is always perceived to be underfunded, but somehow if you can get risk management and marketing involved, the money to develop these things comes along, right? Because if you're doing something really innovative, the marketing people are kind of always like, well, what are we doing that the guys down the street aren't doing? So the money actually came from like risk management and marketing through an internal grant. So hopefully this, 6 to 9 months we'll have data. And, my hypothesis is that this layered learning model of read it, do it virtually, do it in a bricks and mortar situation will transfer over. I unfortunately never got to develop this next product that I'm talking about, but Erika, one one of your competitors, another giant healthcare insurance company, who I'll go unnamed because one of my best friends works there. He's one of the medical directors for one of their product lines. And I had said to him a couple of years before the pandemic, I said, what if I could develop a mobile application that would increase influenza and pneumonia vaccination by, I don't know, 3%. And he said, oh, it would save us millions of dollars a year. And I did the pitch. We did the pitch. People didn't understand. They were just like, nobody's going to really use this. Seniors don't really like, mobile phones and applications. We're not interested. And now I think about, oh, well, how do you schedule a vaccination at Walgreens or CVS on your mobile phone? Like, how are you getting reminders from your dentist office that you have an appointment tomorrow? I know because I just got one. So all of a sudden, it really took, again, the silver lining, it took a really disastrous thing to like, how are we going to reach millions of people to try and effectuate behavioral change? And it was through mobile applications. I have a very good friend, Dr. Lee, who's an internist in China. Everything went to mobile, everything from ordering your coffee to having groceries delivered to listing your COVID signs and symptoms on a daily basis. And I have another friend who's teaching in Qatar, same thing. She was driving to work because she's a director and she got an alert that she was within 15 feet of somebody who had a positive COVID. Fortunately, they were both in cars and not the same car. But like all these things that people were telling me were completely impossible within 6 months of COVID, the money was there to figure out how to do it. So the question for me is like, how do we continue the positive aspects of those trends moving forward? Because my perception is that patients and clients like the convenience as long as the user experience is good. And Erika, you were talking about that. You can't just say, here's the technology, this is what you wanted. So how do we continue to improve on the user experience of these new products? Which has got to do with the user interface, and I'm sounding like a tech geek now, so I apologize. But how do we continue to meet patients and clients at a point? Where's the sweet spot of like, how are we leveraging technology for good as opposed to here's something new, use it?
Yeah, there's something that as both of you were talking, jumped out at me that I think is worth spending a few more minutes on, and that is this, the combination of anytime a team is working on developing new workflows for any kind of new care delivery model, whether it's a model or a type of service, whatever it might be, and the connection to the importance of simulation training, because we're at the same time teaching our clinicians and our care teams how to think about something differently, not just from how they're interacting with the patient, especially if it's through something like a telehealth visit or interacting with an app for training or whatever it might be, but that they're, also learning what the new protocols are that they might be working with and what that means for next steps and how that drives back into the patient's care plan and all of those things. So when we think about your team's experiences setting up like some new virtual care tools and really incorporating things like telehealth and, higher volumes of behavioral health into new care delivery programs, what have your team, I would love for Dr. Pabo, you to share more about, the impact that simulation training had on that project that you were talking about, and how that helped really guide with everybody being remote, the types of different workflows and how that helped you work through some continuous cycles of improvement. Because I think that's a big part of care innovation too, right? We may set out to develop a particular set of workflows to provide care in a new way, but we're going to learn from that. And we're going to continue improving that as a team, to tweak the way that we're servicing our patients. So any thoughts or more insight about that?
Yeah, I think it's critical because it's often a totally different way of working. I would love to say we had really robust like pre-launch simulation, but honestly, and we did do it. We did a ton of work with customers and associates sort of prior to launch of really any of the recent product launches I've been involved in. But I would say most of our learning we had went in with, I think, really thoughtfully developed tools and protocols that were quite different than if we thought interactions were going to be face-to-face. When colleagues and I we launched a virtual and in-home care delivery entity we called Author Care that did in-home behavioral health and in-home palliative care. You know, Tanya Zucconi, who's one of the key leaders of that very well. You know, the protocols that we had stood up were fundamentally different than if we thought we were going to be in person, and had lots more safety protocols and different ways of doing lab testing and kind of, you name it, tech support for the customers, because we had lots of seniors. Although I'll come back to that, because I think seniors get an unfair rap when it comes to technology, because lots of them are using it in their personal lives. They're texting, they're FaceTiming, they're using WhatsApp, you know, to talk with family members. We're just not providing them services that are useful. So they don't engage with us via technology, but I think that's more on us than them. But I would say most of our learning actually came post-launch in really active listening to customers. And we used that as feedback for sort of test and learns and kind of continuous improvement. I think that was critical. So we would do at least weekly kind of customer listening. And I would always ask for the good, the bad, and the ugly. So, you know, bright spot, what's working really well, you know, what are some wins that we can learn from, and double down on things we can sort of, that we think are at least worth studying, and then thinking if there's stuff there that we need to amplify. And then where did things not go expected? Probably more importantly, like where did we fail? Where did something not go as expected? And really integrating that into the culture. We Fridays, middle of the day, were sort of call listening day. And it started out with just the small team that we thought was most relevant, but actually very quickly we had basically the entire organization, the whole business segment would join whenever they could, including all of our frontline teams. And so we'd often have a chat going in the queue to say, you know, can a nurse get on, you know, patient has a need, because everyone wanted to listen to the calls and learn from them together. A lot of our technologists and folks who worked in more back office operations, for some of them it was the first time they'd listened to customer feedback around a product they built. And I think that listening to that feedback and iterating with it was invaluable.
Yeah.
Yeah, I think one of the things that healthcare, and so I'm including myself, I'm not picking on, I'm very purposely saying healthcare and not medicine or nursing. One of the things we've been really bad at is that we will employ all sorts of other disciplines to build a product or to build a thing. And then we don't listen to what all those experts say. So one of the roles that I often play when I build a training platform like this distress platform I talked about is to really, as a clinician and a tech person, get in between the physicians and nurses and in this case, the game designers or the technology designers, because I think what often happens is clinicians do a really bad job of explaining what they want and need to the tech developers, and then the thing gets done. And the clinicians say, this is unusable. And the tech people say, well, it's exactly what you asked for. And so there is always a disconnect. And the reason there's a disconnect is because in healthcare, you know, leaders in healthcare have a lot of academic experience. They have a lot of training. But, you know, don't try and rewire your house. You'll electrocute somebody and burn your house down, right? You know, I'm not interested in fixing. Yes, and I'm not interested in fixing the plumbing in my house either. And I'm not interested in doing the tree work that's going to get done from storm damage in my backyard. And so I think so one of the things that I tell clients in behavioral health is, you know, this is going to be more successful if you can trust the process. And sometimes it's going to get really ugly and messy before this, you know, flower blossoms. And I think it's the same way in technology projects. Is there is like some contention between the people that are coding and doing, you know, doing all the coding, programming, inventing, building, and the clinicians. And there gets to be a point, I think, where you're like 2/3 done, where the clinicians are like, oh my God, we spent all this money and it's never going to work. How am I going to justify this? I just spent $1 million or $10 million to the CEO. And I've done it, and I've had those panic attacks, and I've had enough sleepless nights that I can take a deep breath and just hand out the Tums. It's gonna be fine, as long as you get your fingers out of the, you paid a lot of money for this product. You have to stop trying to micromanage it, because otherwise there's two things that are going to happen. If you don't, like, you're using an application-based technology or solution or a game-based solution, you have to let the game designer do his thing or her thing. Because you don't know how to do that. No more than they know how to treat sepsis. So, like, don't ask them to treat sepsis. You don't tell them how to design a good user interface. And the other thing is, there is something to be said about, at some point it has to be good enough for launch, and anything that's digital is a living thing, and you're gonna need to update it. Unity is gonna change. Some plugin on Android is gonna change, or on Apple. And so if you try and wait until all of the leadership and all the stakeholders are like 100%, it's good to go, one, you're never gonna launch. And two, if you don't launch to the broad audience, you're never gonna have the opportunity to fix things along the way, because there are going to be things along the way. So I think that, what simulation is really good for is threat assessment. Ooh, if we keep doing it that way, there's going to be bad patient outcomes. Well, it's the same way in like a digital technology, is like you run that simulation to see what the threats are, but eventually you've got to release it into the wild. And you release it in the wild once you're confident that it's not going to do any harm, but you absolutely have to understand that you're going to release it into the wild. And in 30 days, you're going to have to go back and change a whole bunch of things, because some stakeholder hated it. They don't like, the user interface was crystal clear to Erika and I, because we're clinicians. Of course you'd push this button, but it's not to somebody with a 9th grade reading level or a 7th grade reading level.
Yeah. So as you were both, talking about this, I call it this new match of, or this new blend of, continuing to deliver care, some in person, but a whole lot more virtually and with the aid of technology and, all new IT enablement plans that are out there. Have you noticed, as your teams have gotten more mature in these areas, differences, whether they be positive or negative, with a lot more care being provided virtually? Would love to hear from both of you about that.
Well, I think in behavioral health, our cancellations and no-shows have gone way down. My first clients of the day, I was on the way into the office today, and our secretary sent me a text message and just said, "Oh, by the way, your first client's going to be virtually as a sick kid." Well, 2 years ago, if you had a sick kid, it would just be a no-show. And so now, in behavioral health, you always have I think you have a higher rate of no-shows than you do in cardiology or something, because people are like, "Oh my God, am I having a heart attack? I need to have this follow-up." They'll go. And behavioral health, part of the reason they're behavioral health consult is because they have behavioral health challenges that prevent them from being consistent. But I would say, now what happens is somebody's not here, they're 5 minutes late, our secretarial staff will call and they'll be on my Doxy thing. So they're 5 minutes late, but they're not gone. So I think for us, what's really interesting is a lot of times I'm still sitting in my office, but instead of a no-show and me like swearing under my breath and then having to deal with, I write for a controlled substance for this person, they're not showing up. The next thing I know is I'm going to get an angry phone call that I didn't refill their amphetamine for ADHD, which I really don't want to do unless I've physically seen them. So those are going away. So I think it's really helped there. Interestingly, the senior partner where I'm working he's been a social worker since 1973, all through COVID. He came to his office and saw his full client load from his computer. And the rationale for that, he's like, when I'm in my office, I have my therapy hat on. When I'm at home, it's off. I can't do therapy from home. So it still allowed Tim the ability to wear his social worker and therapy hat and provide services, because he came into his office, there was nobody here. It was perfectly safe. It was legal for him to do it. But it also provided the opportunity for his clients' needs to be met. And, if you think pre-telehealth, the clinics are just closed. That was it.
Right. Yeah, absolutely.
Yeah, I think it's interesting. It's been an interesting, and it depends a little bit whether it's behavioral health or primary care. And I think it varies a little bit by patient demographic and population, but it's interesting to look at how percentage of visits being virtually versus in person has kind of changed over the last 3 years. And we had obviously the initial sort of dynamics we talked about, but it has felt like recently we have not fully gone back to ways of working prior to COVID. But it has been amazing to me how persistent, sort of all throughout a care team, like from the front desk staff to the MA, to some providers, to some patients, this thinking that we should, it has almost felt like a regression back to some mean, that somehow in-person care is better. And so it's interesting, I've seen this in a lot of practices, like front offices, the front desk has a bias that if there's a virtual visit available and an in-person visit, they should offer the person the in-person visit and not necessarily give the patient a choice. And so I actually think we have seen an overcorrection as an industry to where we are today. And I think it's incumbent upon us to continue working with our patients, with our customers, and with our providers to figure out what that right balance should look like. And I think it's going to be different for an SMI population versus endocrinology visits, like what that balance optimally is, both from a patient perspective and from a clinical, like what you can do as well virtually or better virtually than you can do in person. But I think we have gone back closer to pre-COVID than we could or should be in sort of realizing the promise and potential. And so one thing we're going to start experimenting with is actually offering different products to customers to sort of test and push those boundaries. So we Humana, and you might talk about sort of Conviva and Centerwell, I would say we have one of the best in-person senior-focused primary care experiences today. I think we offer a really wonderful in-clinic experience, and we have virtual and in-home capabilities that we offer to our customers, but we're going to experiment with launching new products that sort of flip that on its head and say, can we offer the same bespoke team-based senior-focused primary care offering, but 90% of it is going to be virtual. And we're going to figure out with customers, do they want that last 10% in home or in clinic? And we're kicking off that work right now. But I think we may actually need to push the boundaries back to those early days of COVID to help us figure out what that balance should look like. Like you see that in the banking industry is an example I often go to, because I think there are some things that are similar to healthcare, and then it's like personal information that people often don't want to share, and obviously there's lots of differences. But you look at banks starting to offer virtual only products, like you look Marcus by Goldman as a savings account. They don't have offices; you can't go in. Like there's nowhere to go. But it can be a great product for certain people for certain uses. And I don't mean that we should do that just for like urgent care, but I think even things like comprehensive primary care, complex behavioral health care can be done in a exclusively or close to exclusively virtual, or at least wall-less setting.
Yeah.
I think one of the things that we're missing, and you know, I am an academician kind of at heart. But it applies in both the clinical setting and the academic setting. Why is it that we were all forced to go to lectures with 300 people in it that were not good experiences for the professor and were not good experiences for us? Well, because that was the cost-effective delivery method. Like, so my father was a calculus professor, University of Wisconsin. I mean, probably the best way to teach calculus is not one guy and 500 people and then a bunch of TAs. But we did that because it was cost effective. And how else do you do that on a campus that regularly has 10,000 undergraduates that need to take calculus? So then why is it like, and then the first place I worked as a nurse was in an urgent care, and we would schedule 4 to 6 patients and we tell them all to be there at the top of the hour. And the first one there got room first, and everybody else had to wait for 45 minutes or an hour to see Erika. And they would all scream at me because I was the triage nurse. Well, why did we do that? Well, because it was efficient for the clinical practice to have everybody there at the same time, because then you didn't have to deal with 2 no-shows in a row where where the PA or the NP or the MD wasn't seeing anybody, right? So there would always be somebody in their queue. Well, that's a horrible experience if you're the fourth person to check in. It's a great experience if you're the first person to check in. So we weren't doing that because the lecturers weren't there to meet the students' needs. They were there to meet the university's needs. And the way we often do in-person clinical encounters meets our needs. But the virtual doesn't require somebody to go pick up their kid from school, drive them to the clinic, take off 3 hours from work, drive them to the clinic for a 10 or 15 minute or 20 minute or 30 minute appointment with me or with Erika, then get them back to school. That's 4 or 5 hours of their time. So I think we have not, behavioral health likes to use the term clients instead of patients. I'm mixed on that, but the point is we haven't been treating our patients like clients globally as healthcare, as if they can't go somewhere else. And I think the same thing I've said about technology in academic settings, like the schools with the best technology and the best use of the technology, that's where the best students are going to go. Right. So if Harvard says, nope, we're only going to do bricks and mortar and we're not going to do anything online, well, then people stop going to Harvard. So I think what you've described with Humana's new launches is brilliant, right? If this is what the patients or the clients want, and this is also going to be a good thing in terms of best practices, in terms of outcome, and it's also going to provide the opportunity for less expensive delivery of services, then we're foolish not to do it. But then there will always be some shot caller that says, I'm 68, I'm going to be CEO for 2 more years. When I'm gone, Erika, do whatever you want. But until then, this is the way we're doing it. And so it's like getting over those humps. But you're right. Like, I just can't imagine what percentage of my clients that would just be complete no-shows if I said, nope, I have to see you in person every time I see you.
Yeah. So I'm curious, from each of your different perspectives, and being, clinical leaders as well, with all of this change around how we're trying to figure out the right balance of in-person and virtual care delivery, are we seeing the inclination of change for the reimbursement opportunities in the market to support us, continuing to figure out this right balance as well? Would love to hear more thoughts about that from either of you.
Well, I know that, one of the things, and Erika, she clearly is going to know more about this, so I'll just be very brief and then turn it over. But one of the things that's come up that never had to come up is that we have to indicate in our notes, in your medical record, however you're doing it, but you have to indicate whether it was a virtual telehealth or in person, because even though the outcome may be exact, look, if I'm an orthopedic surgeon, like a virtual hip replacement just doesn't work. Although we've made huge advances with virtual reality, with surgery around the world. But that said, from day-to-day clinical practice, you just don't get reimbursed at the same rate based on Medicare, Medicaid reimbursements if it's a virtual versus an in-person. And so I understand that. Maybe that, like, if I'm seeing the rheumatologist, I don't know. But for like behavioral health, the outcome of the encounter is exactly the same. But obviously, Medicare is going to drive like what the reimbursement rates are across the industry. And if you get a lower rate because it's virtual, I'm not sure that I think that that's such a great idea. And it goes back to what Erika says, where the front office has this bias, like in-person is better. Well, if in-person means they're not going to show up for their follow-up, it's not better.
Mm-hmm. Yeah.
So, I'd be really interested to hear your thoughts on that, because the insurance industry really led the way with like telehealth pre-COVID. Like, okay, if you're willing to do this, you can see you get 24-hour access to a clinician.
Yeah. I think it's really interesting. I think we would not have seen the shifts we did in care delivery had payers, sort of broadly defined, both government and private payers, not really changed the game and what they were willing to pay for virtual care sort of as part of the public health emergency. And I think we've learned a lot from that, along the lines of what we were talking about, that for the most part, you can provide as good or better care virtually. And so we should pay for that, because that's the whole point, is we pay for things that have value, or that should be the point. I think and then when you look at like value-based models, I think allowing folks to document conditions and all that over virtual visits, and learning that one can do that in the same way that you can provide care as accurately and well sort of virtually, were critical to enabling care to happen the way it has over the last couple of years. And I think we need to take all of that forward. I think some interesting questions around what the exact right sort of payment is. And I say this as myself and sort of not on behalf of Humana, but I think where we have a lot of learning is there are certain things that you need in a brick and mortar setting. You need bricks and mortar, you need an office, like you need front desk, you need, in lots of clinical practices, you need RNs and MAs. You need most of those things in a virtual setting. Maybe you don't need the bricks, but you don't not need some sort of front desk or tech support role. You still, I think, to provide good care, you need a care team. If all we did through tech enablement of care delivery is replace an in-person visit with one clinician, a visit with that same one clinician virtually, we've actually taken like decades of steps backwards. Because if I think back a lot of the progress sort of prior to COVID, would have said a lot of that, at least in primary care, is around team-based care and really having like high functioning teams working together. And so you need all of that in a virtual setting. And so does that mean parity is the right answer? Maybe. But I think that's where we still have learning, and we also need to see the costs of some of the technology tools continue to come down. But I think we absolutely there's absolute value in the care delivered virtually for all the reasons we've been talking about, and it is a payer's job to enable that. And we did that during COVID. We have to continue, but again, like, what are the services and how do you pay for that outside of a fully value-based model? It's actually a lot simpler in a Medicare, managed Medicaid sort of setting, which is primarily the space I sort of work directly in. But I think there's like more to figure out in more fee-for-service models.
Yeah.
Well, I just want like quick things that Eric brought up that are just like essential. And the first is, if the client, the customer, the patient thinks it's value added, for some people, being able to log on and talk to your pediatrician or a nurse practitioner at 2 o'clock in the morning about an earache or a UTI or something, to them, they probably, I know they do, they would rather do that than have to go in the morning to see the pediatrician or the nurse practitioner. So it's like this like mismatch, right? The patient or the client thinks this is a great idea, we should do more of this. And the overarching like machine hasn't figured that out yet. The other thing that is this does not have to do with healthcare, it has to do with anything. When people make the assumption that technology-based something is going to be cheaper, it's only going to be cheaper if you pay for crappy intelligent or technology enhanced something. If you want a really good product, it doesn't matter whether it's a bricks and mortar product or it's a technology enhanced product. There's a cost to doing that sort of business. And Erika's exactly right. It's not as though because we are seeing a client from home during COVID, it doesn't mean that the front desk is still doing something. The pharmacy is still doing something. So there's all these things. So it is not cheaper to do technology. In fact, I always say that technology for the sake of technology will always be a disaster, right? It has to be purposeful.
Yeah. I think the thing that matters the most to me these days is that we're all willing, because we've seen that these, the blend of the physical and virtual care can work. And now that we have the data that shows, hey, there's, good value for this, that everyone is, I think, at the table willing to figure out new reimbursement models. And that to me helps, strive for the change as well. Because honestly, before the pandemic, BP or BC, before COVID, we didn't have those reimbursement models available. And so that was another positive change for everybody, right? That we had the dollars behind providing that type of care, which really matters too. So I think, I love what both of you just shared, and I think we're moving in the right direction, which is exciting. There's a question through chat that was shared, and it is, somebody is curious about which companies are effectively utilizing gamification of medication and chronic condition management, diet, et cetera, to improve outcomes within the US and outside of the US?
So that's a great question. And as soon as I read the question, the name of the company just popped out of my head. It was, I want to say Blue Marble or Blue, it's not Blue Origin because that's rockets. But so there's a couple of companies, Blue something, and they're on the East Coast, and they have some of the first games or game-based applications that are FDA approved as treatment plans. So I dare say FDA approval, the search terms FDA approval, Blue treatment plan, pediatrics, and you'll find it. But you're also starting to see the use of virtual reality trials, specifically for post-traumatic stress disorder, desensitization, and that's all going on at the VA. So like when you say which companies are doing it, I could rattle off a whole bunch of DoD contractors I know, and it might be the right ones or not, but that research is being done in the US through the Veterans Administration, some really great stuff. In terms of Europe, I only know the company that I did the game with for University of UMass University of Maryland Medical Center. They've done a whole bunch of things with nutrition and diet in Europe. It's called Grendel Games in the Netherlands, and Tim Lanning is the guy there. So in full disclosure, I sometimes do consulting with them. But if you can share, your chapters can share my email address, and if people want to follow up with me offline, that's perfectly fine. But the salient point is, in the US, the VA, and in pediatrics, there are now some USDA approved gamification or game-based learning applications for actual medical management or healthcare management of chronic disease. The first one that was done was actually done with visualization in burn patients. And that one's already 10 years old, but it was way ahead of its time. And actually, I was at a HIMSS conference in Washington, D.C., where I first learned about that because I introduced them in the games track of the HIMSS conference in Maryland or D.C.
Yeah, I'll add a couple of vendors in this space. I don't know if this quite counts as gamification, but it came to mind because I feel like the newer developments inside the metaverse, trying to align this virtual reality experience to healthcare. There's this really exciting pilot being done by D-Health, is the name of the vendor in the UK. And it's all around connecting the virtual and physical in-person care delivery inside the metaverse. And I think the pilot has taken place throughout this summer. It's still ongoing. I think it included, I want to say 3 million UK residents. So I've been watching for the data, to be released on the outcomes of that, right? And the types of things that we can learn. I feel like our academic centers within the US are very much starting to use more like augmented reality, virtual reality for surgery assists. There's things out there like AccuVein that are helping our nurses get an IV inserted on the first try, because we all know, unfortunately, 40% of the time we miss on the first try, right? And that's painful. I can speak to that as a patient who always has problems finding the vein for that. So it's things like that I definitely am hearing more and more about. Dr. Pabo, I don't know if there are other things that came to mind from your perspective.
No, I think those are all great examples. And I think there's super interesting potential in VR, especially for proceduralist sort of specialties that I think are super interesting. I have to, not to be a wet blanket, I think there's a lot of potential in sort of gamification. But honestly, we have so much trouble just providing sort of proactive response to needs in the channel that someone wants in the moment, that I'll be honest, I'm more focused day to day on what I would consider what should be kind of table stakes in the industry and just aren't. So I think there's a ton of potential there. But I think we also have a lot of kind of bricklaying of those basics to do. In part because I would want tools like that to integrate seamlessly into a stronger kind of home base. I think that's one of the big challenges I see, not to end on a sort of more down note, but when I think about things that aren't working well, one is the risk of further fragmentation through new tools and technologies. And technology has the potential and power to integrate and provide more seamless experiences across silos, but it also, if we're not developing it intentionally and sort of designing for integration from the outset, it has the potential to further fragment. And so I don't, if someone has chronic disease management for diabetes that they're doing in one sort of silo, and they have their behavioral health care across psychiatrists that they see in person and virtually, and they're using an online tool for some self-management, and none of those talk to each other, and I, as their PCP, can't see any of that. It begs the question, have we really made things better? And so I think there's a ton of potential, but I think we have to design for that kind of integration and breaking down of silos sort of along the way.
Yeah,
I think
I know there's a lot of work in the behavioral health world to connect the data too. So Eric, would you like to comment on that?
Well, I was going to say, well, two things. Erika's right. Like, we have to, the challenge we always have, right, is that like disparate tools, like something that only works on Android, or something that only works on OS, and something that only runs on Chrome versus something that only runs on Microsoft. So that's a problem. But so this was 2010, 2011, I gave a keynote at the American Dialysis Conference. And I said, the place where this is going to make the most difference is patient education. And people are like, what do you mean? I said, well, as a registered nurse, staff nurse, my job would be to walk into the room and say, so you saw Dr. Erika, and she wants you to take this medication, and she wants you to do, this sort of wound care. Here's a pamphlet on it. Do you have any questions? No, I don't have any questions. And I worked in the ER as a staff nurse, so it was like 3 o'clock in the morning. Do you have any? So, and no, okay, great. And I'm out the door. And we empirically know that doesn't work. That just doesn't work. So like when it comes to like chronic care, like where it makes a huge difference, like dialysis, what if I just say, oh, this is my phone, but here's an iPad. This iPad has all of the patient education. It's using game-based learning as a tool to map back all of that data, then goes right into a dashboard for whatever healthcare organization that Erika is working for, and any clinician can get to it from the electronic medical record. And people are like, but we'd have to supply people with $300 iPads. And I'm like, well, if your outcomes improve by 5%, you're making more money. The cost of the iPad or the thing pays for itself. And that also eliminates the problem that Erika's talking about. So, I mean, that's where I leave you with, like, patient education, and it's doable. It just takes people that think like HIMSS people to make it happen. So I'm taking the wet blanket off, I'm putting it in the dryer, I'm fluffing it, and I'm putting it back on the client.
I can't believe that we sped through this hour. I knew it was going to be a great discussion with both of you here, and I just want to be mindful about your schedules and everyone listening. So really quick, Tanya, I think the things that we highlighted the most for everybody is, don't be afraid to have a continuous cycle of learning, because for care innovation, that matters, right? So continuous cycle of learning and improving. Listen to the folks that you're serving for feedback. Think about simulation training in new and different ways to, reinforce the new workflows. And, we're all working through this balance of trying to figure out what's right for in-person and virtual care. So we're in this together, more to come. I'm really excited to see what 2023 holds. And thank you both again so much for being here. Tanya, I'll turn it back over to you for closing.
Yeah, thank you so much. I can't even believe that was an hour. Like it was so, it was great. So thank you again for participating and supporting the HIMSS Arizona chapter. The discussion was great. I do want to, for those of you that are still on, I did not have the name of our next week's meetup, but it is at Ideas Collide in Scottsdale. Make sure you check it out. It is on our website now. But Dr. Erika Pabo and Dr. Bauman, thank you so much again for joining us. And Tina, thank you so much for the great discussion and putting this all together. I really appreciate it.
My
Thanks,
pleasure.
Tanya. We
Thanks so
appreciate it.
much.
Thank you.
Thank you.
Thanks. Take care.
Bye.
Bye.